Hello and welcome. My name is Dr. Art Rastinhad, and today we'll be discussing MRI segmentation and planning for focal therapy, a urologist's guide. Our goal today is to cover the basic steps and tips and tricks on how to improve your processing and planning for focal therapy. These are my research disclosures. The only thing that's pertinent for today is that I do show some images from the Philips platforms that we're developing for focal therapy. The evolution of prostate cancer has been very exciting for the last 150 years with advancements. Since 1853, when Dr. J. Adams first described what prostate cancer was, to the progression of Hugh Hampton Young describing the perineal prostatectomy in 1904, Dr. Huggins demonstrating the impact of androgens on prostate cancer and the impact of castration. In the 1980s, it was really exciting because we had the development of PSA, but more importantly, the biopsy needle and guide for an ultrasound-guided biopsy of the prostate, and Dr. Walsh's initial description of the prostatic nerves, leading to the formal technique of the nerve-sparing radical prostatectomy. And in 2009, the NIH describing and producing the first MR ultrasound fusion-guided biopsy platform. And what we're discussing today is if you can see it, you can biopsy it, you understand the biology of disease, you have different genomic classifiers, maybe we can work on treating just that location. We understand prostate cancer is multifocal, but focal therapy does have some data supporting the idea that we can maintain cancer control without sacrificing a man's quality of life. Who's a candidate and how big of an opportunity is this in your practices? A publication from the University College London, Dr. Emberton and Moore and Hasha Med's group at the time, 51% of the patients that had a radical prostatectomy could have been candidates. Who are the candidates? Typically grade group 2 or 3 or less, PSA less than 20, localized and focal disease. And the goals of focal therapy is to maintain a cancer control by not compromising a man's quality of life issues, erections, and continence. Key factors in planning focal therapy. A lot of things go into this. You have to have a partnership with a radiologist, high quality MR imaging. As a urologist or a urologic oncologist, you have to understand the biology of disease, make sure we're working to minimize the risks of multifocal prostate cancer and missing that in the planning and the workup towards focal therapy. The type of biopsy performed, was it transperineal, was it transrectal, was there fusion, was it cognitive? Basically today, a standard biopsy does not give us enough information to plan for focal therapy. What kind of CAD system are you using? Are you able to manipulate and review images as a urologist to plan for your treatments? What energy and what focal therapy platform are you using will go into your planning and how you denote the lesions. I'll discuss a little bit of this through the talk today. And transitioning from the treatment to post-treatment plans. How long is a Foley going to be in? How often you're going to obtain a PSA? What type of patient-reported outcomes are you obtaining? Post-treatment imaging and biopsy. A lot of time when working, I feel like we look at what is state of the art. This is sometimes what I feel like our practices look like when there's so much more opportunity to implement technology and new types of therapies into the urologic armamentarium. Notice that they're watching a black and white TV of ultrasound. The prostate. At one of the FDA sessions, they refer to the prostate as a chicken nugget of cancer. You can freeze it, fry it, steam it, microwave it, electrocute it, stuff it, and cook it. There's lots of opportunities for different treatments. These all represent current modalities that we have available for our patients today. Some are in research and some are FDA cleared for prostate ablation. Quality and patient selection. How do you maintain this and what are the optimal ways to do this? MR imaging is the mainstay. If you have bad imaging, you can't diagnose and assess a margin for treatment. You also have to struggle with the interpretation of the imaging itself. It's really important for you to have a second set of eyes to take a look at these scans when they're obtained at the time of biopsy, and even more importantly, at the time of proposed possible therapies with specific to surgery and or focal therapy. One of our challenges in dealing with who's a candidate is who does the biopsy and was it done with fusion? I don't think there's a big difference between transperineal and truss in assessing uh, the diagnostic quality respect to is there cancer present. However, I want you, if you're doing a transperineal procedure, like you're going to do cryo, IRE, focal laser ablation, any of these technologies that they're using a transperineal approach, it's so much easier to see where the tumor was within relation to the prostate when you set up and you do the biopsy. So when you go back to do the treatment, it's that much easier because you already have a roadmap. You've already practicing the patient positioning, and it makes it really easy to perform the treatment. And then about fusion, I don't think the focal therapy should be done without the use of fusion. A cognitive biopsy and a cognitive treatment is just prone to so many errors. It's much easier to have these fusion biopsy platforms that record all the information that allow you to go back, reassess, review, and then plan the treatments. Because any of these issues within this few points can really affect the outcome of your treatment. Speaking of MRI quality, there's 3 papers I'm going to cover here. This paper basically showed reported that you should have a possibly 10 millimeter margin to have adequate coverage with respect to the lesion and planning, showing that sometimes the lesion that was proposed by the radiologist may be smaller than was actually seen on pathology. But this goes back to your foundation of how you develop your program. If you mark the MRI for biopsy, not total treatment of the areas, you may have an underrepresentation. Also, when you look at the scans, the B and C are the T2 images. If there's low resolution, lots of noise, it's really hard to see where the tumor starts and ends, and you have to use a multi-parametric approach to plan your therapies. This is another paper going over the same topic of how much does the MRI under assess the size of the lesion. There's a lot less in this series, and they recommended a 9 millimeter margin at the time. And the first study that predates those prior 2 studies was a study from the NIH in 2012. This study demonstrated that the tumor underestimation was much lower than the prior 2. Why is this? Most likely, if you look at the scan, the T2 is a high quality image T2, and you can see the capsule. You see delineation of the transition zone and the peripheral zone. You have an idea where the margin is, and I think this gives a better representation of the actual tumor volume. So in summary, when looking at this, you can see the higher the quality of the image, the less that the MRI is underestimating the type of the amount of tumor present. So it's really important to work on the quality of MRI prior to performing focal therapy because no one needs any surprises at the end of the day. This is to give you an idea of what high quality MRI can look like. I think it's important to know what you can have because then you know what you don't when you're looking at your own studies, and you can speak with your radiologist about improving the quality of the scan. I still do that in our current program on a monthly basis. We review the MRI quality, which sites are doing well. Is this a tech issue? Is this a technology issue? Are the patients not having adequate prep before, too much air in the rectum? What can we do to make this better? So now let's get started. There'll be some videos coming up where I've narrated. Please pay attention to the buttonology, how we approach how to see the image, how I process the image, and there's a lot of important steps you may have to watch more than one time through. But I hope you enjoy this, and please give feedback, and we can always improve the videos if you feel like there's areas that you would like us to have more detail on. Thank you. The first step with any case in focal therapy is reviewing the images. This patient underwent an updated MRI, and we're reviewing it here. He has a left mid base TZ lesion or possible apex. We look at our PIRADS info that has been collected for the case. His PSA is 5.9. The ROI overlaps these regions as seen here in the pink, and it's a PIRADS 5 lesion due to the size. Once we look at it, there's different sequences. Across the top, we typically review and have a high signal or diffusion weighted imaging that helps us visualize the lesion. The ADC is in the bottom middle, and up here in the upper right area is our dynamic contrast enhanced MRI. Interestingly, once we complete our initial review and the candidates for focal therapy, I do the gland segmentation. we create the outline around the prostate. This is important because the patient had a prior biopsy before, and we're going to merge the biopsy cores and the pathology with the updated MRI for planning purposes. As you see here, there's some commands that we're using. They're outlined. You can choose in the lower right, or I have shortcut keys. When you see the hand, it grabs, it stretches it in, and stretches it out based on how big of the yellow piece it's grabbing. If you want to make it smaller, I hit the control key, and smaller or larger. You can see it's just changing the elastic band, that yellow on the green margin. Typically, we start with a larger one and then work our way down to smaller for more fine tuning. You can see this is a reformatted image. It's a one single T2 that's been turned into a sagittal and a coronal to help with our segmentation. This part is key because we want to make sure we have a good representation of the size of the prostate, and gives us the ability to merge this with the prior MRI. I think we're pretty good here in this space. I hit approve. So now I will show you where what the prostate looks like, which was based on this T2, but we can see it on any of the other sequences. Notice that there's some misregistration of the other sequences. This is important to understand. The misregistration is due to the fact that the patient may have moved, and the T2 we built the segmentation on was built on the T2 in the upper left. And we see our lesion again as it was labeled by the radiologist, left TZ mid-base. We talked about the PIRADS representation of that from the Dynacad system. We'll outline and tell you where your lesion is in pink, and gave you a description: left mid anterior TZ and left apical anterior TZ. And this is our index lesion for the case. The segmentation has been completed, the outline of the prostate on the T2, which we used for the planning and treatment. We have the left mid TZA lesion, mid to apex in the 3D mapping. But he had a prior biopsy and he was trying to determine therapy. So in that time, more than 6 months elapsed, and we repeated the MRI. But I want to look at his prior pathology specimens. So we recorded and tracked everything in 3D. In this step, we co-register the prior MRI segmentation with the updated one. You can see we have pretty good fidelity between the two segmentations. So we're able to co-register these MRIs together, and now I can see exactly where all the cores were taken in relation to the new MRI. So you can see all the biopsy cores that were sampled and their locations within the lesion, as well as the ones adjacent to it. We use these for tracking the lesions. He does have a secondary lesion down here at the left apex PZPM. This was just atypical cells, so we're continuing to follow them. As well on the right side over here, some non-specific changes which were also sampled. You can see the cluster of the biopsy cores recorded in 3D. It's important during the procedure that your assistant records them in the correct position, and the challenge is sometimes they don't always mark them correctly because people are progressing through the biopsy at a somewhat rapid pace. So again, you can see this, and when we look and review, the pathology on core 23 was negative. This helps us understand this is a truly transition zone lesion. We have peripheral zone sampling that is negative, so it reinforces the idea that we can focally treat this area of the prostate. Now, planning the procedure after we've created the map of the biopsy core, so we know what was positive, what was negative on the biopsy. We review the segmentation and we feel this is adequate for the procedure, the outline of the prostate, as well as the prior target from the radiologist. As when we're planning, it's important to use all the features of the MRI to help outline. Typically, I use a 6 to 8 millimeter margin, depends on the location of the lesion. But I want you guys to understand is, so we draw, here's where 8 millimeters is, or 6 to 8 millimeters. And you can get an idea is that not everywhere is going to be able to have this because of constraints of the size of the prostate and the location. It's important to visualize with this type of software and this approach, we have to spend more time trying to figure out exactly where the lesion is. The most common mistake people make is not looking at lesions in the z-axis, which we're going to look in the region in the z-axis over here on the sagittal plane to see where we need to plan the treatment and how to make sure above and below is adequately covered for this patient's treatment. So I want you guys to understand that how can we do this? Well, you can add a ruler and add the 8 millimeters above and below in the plane of the prostate and just understand where things are, because as you scroll through, you want to know where the sphincter is, how far away from the sphincter. Before I draw the margin, I'm going to review the fusion biopsy material and information from the procedure itself. So we're going to switch to that. When performing focal, I think it's important to always review the MRI fusion biopsy information. It's always tracked and recorded depending on the system and where you have access to it. This is all through our Dynacad system, so our radiologists can review this as well as the urologists. The segmentation we review. We see how the MRI lines up with the ultrasound. Does it really line up well with the prostate during the procedure? How well are the needles tracked? Are the people placing the hashtag at the tip of the needle? Because you know there's some dead space between this perpendicular line and the beginning of the yellow. That's dead space from the needle tip. There's no tissue taken from that. So hopefully when we sample the areas, we always make sure we're covering the entire area of the ROI and sampling it. So we're looking at this. What else is important to look at? This was some atypia that was appreciated, but the biopsy was negative. Looking at the relationship to where the rectum is. Is there a gap? Could you perform hydrodissection? There's plenty of room to perform hydrodissection, depending if you're doing cryotherapy, IRE, laser ablation. It doesn't matter the modality, just determine how to protect the rectum, and then appreciate where the sphincter is. In the lower right-hand corner, I don't know if you appreciate when the video started, you can see the location of us sampling in the 18-gauge grid. In IRE, wherever you place the needles, they can be no further than 2 centimeters apart, as well as they create a 5 millimeter margin on the outer edge away from the needle for the ablation zone. So we can see the grid, we can see how we can line up the treatment plan. You can easily put a box around this, plenty of room to work with. And with IRE, you have less damage to the urethra. With cryo, you have a warming catheter in if you need it to protect the urethra. And finally, the sphincter is the most important. So we've reviewed the pathology. You can see how we now, as we scroll through, we look at our different regions of sampling. We typically focus on the peripheral zone. But this left lateral one was important. It was lateral to the lesion, and there was no cancer appreciated in that biopsy course. So that helps with our planning. We know that it's truly a transition zone lesion. And then sampling on the other side. And this is the review of the fusion biopsy. I think is really important, and you guys should focus on this. And most of the challenges I've had in my practice is when I have referrals from the outside for focal therapy, I don't have the opportunity to review this and be the one performing the biopsy to know how we can set up the practice for a transperineal procedure. I believe transperineal biopsy is a great way to practice and build into focal therapy as a skill set for yourselves. So TP biopsies, I typically recommend doing at least 20 and feeling comfortable with that before you move into transperineal modalities for focal therapy. In the last step before the procedure, we review the MRI and take into account all the sequences. Again, T2 is on the upper left, the DWI B2000s in the middle on the top row, and the DC on the left, the ADC in the bottom. We have a coronal on the right lower line, as well as a sagittal in the left lower corner. Depending on what margin you want to create and where your area of focus treatment is, these are a lot of factors. Again, we're going to go over measuring just so you have an idea of what is what, the length. We know the width of the tumor is about 1.1 centimeters. It's listed on the UroNav, and then the longest length over here is 1.4, and it's 1.6 in its z-axis. So that's our diameter, just so you know where things are. It is approximately from the edge of the lesion to the capsule, 6.2 millimeters. Posteriorly, we have a lot of room to work with from the lower edge of the lesion down to the posterior wall is 12 millimeters. We'll set this margin around the edge at 5 where we'll place our needles. So if you go 5 millimeters away, you have to kind of gauge where things are. Remember, this is in three dimensions. So I'm going to get rid of this one because every time I touch the prostate. So if you put the probes 5 millimeters around the edge, you're going to have 5 millimeters past that. It'll be over a centimeter ablation zone. But for the sakes of trying to learn how to segment and target, I'm just going over this. So now, once you kind of have an idea what 5 millimeters looks like, we're going to create a new ROI and draw it around the edge of the lesion to cover our proposed ablation zone. If you're doing cryo, depending on the brand and needle, you look at how long the diameter is of lethal ice. You can see that we have encompassed a good margin of the peripheral zone because we know there's no cancer there. You can see where the prior biopsy cores were in relation to what was treated, and these other cores down here, core number 23 was negative for cancer. So we have an idea where everything is. Now, this ROI 1, we click on Make 3D. And the cool thing about this is that you can leave your mouse in one area, and then when you go to the next slice below, you know where it was again. So now we can create a very similar ablation zone, and if we don't like what I did, I can fix the top by just making it a little wider. I'll move my ROI over the top of that. And then I can make this a little higher here, and it'll fill it in. It tells you the diameter of your ablation zone. And the important thing is, depending on the technology you use, you can plan accordingly when you get to the planning side in the OR on the day of the procedure. Now you notice that it's getting smaller, so we're kind of coming in. We can see different parts of the anatomy of the prostate. I went a little too close there, but I will go back and fix it. Oh, that didn't fix it, did it? So we're going to go back around the prostate. And that comes out. Oh, there's nothing there. Now, this is my pet peeve. Z-axis. So you see where your ROI is, right? You see where the outside, the blue, the proposed ablation around the purple ROI where the tumor was. We're going to draw another ablation zone almost identical to the one above it, because that's 3 millimeters. As the prostate disappears, we'll draw it smaller, but now you can see that we're going to create this 6 millimeters past the edge. So now, if there's any tracking issues, we're covering our area. And again, I'm going to draw another lesion. The ROI around my proposed area. Now it's gone. I'm going to draw it again. So I want to make sure that we treat in both the z-axis. So that's only 3 millimeters above. Other people forget to do this part. So we're going to go back and look. And I am just kind of putting this ablation zone around the area. This doesn't tell you where to place your probes, but it tells you what area you need to cover during the treatment. So I'm going to end the edit. I'm going to name that ROI ablation. So I hit save. And now I've at least created a map for our treatment plan. If you look at it in 3D, we can look in all the different planes by just using the same plan to make sure you have a z-axis that you've covered from the top to the bottom. And I think we have really good coverage, and you can see that. This is just a reformatting button in the lower right-hand corner. But if you push this gives you a 5 millimeter margin of what's drawn. If you put your needles, if it was IRE on the outside of this, this would create an additional 5 millimeters. And the needles have to be 2 centimeters apart, so you can plan that for the procedure when the patient has the procedure done. Pretty easy, straightforward. This is an example of Dynacad 5 Urology. This is part of our research project developing a way for us as urologists to review procedures afterwards. This shows us information about the prostate in the upper left, how big it is, each lesion where it's located, if it was positive, how big of a volume of prostate tumor, what are the dimensions that were mapped for the procedure. And you can also map and put down corresponding pathology on additional cores. This is a way to visualize the post-biopsy, as well as, if you like, to watch a video of the procedure that was recorded. There we go. And we're able to buffer through the video, and you're able to review everything that's occurring during the video and during the procedure. So that if there's an issue with it, this is just sped up, just seeing what's happening, alignment, everything else, and this can all be evaluated. So when you perform your treatment, it gives you a better insight of what to expect. There's a little HPI. So we have moved from reviewing the case in Dynacad 5 Urology, where you could have looked at the videos and all the aspects of the case. And this looks very similar to what you saw before, but it automatically put a margin around the transition zone. And we can, if I don't like this one, I can delete this margin. Okay, well, let's create another margin. Let's say we put in, default is 8 millimeters. You want to see what it looks like? Boom. It'll show you the margin, and the margin is extended full in all directions around the prostate. Notice that in the top window here, it could appear that you're treating outside the prostate. That's what happens with cryoablation. It's not restricted to the prostate. But you know, you can see how big a 8 millimeter margin is. And if we don't like what it looks like, we can adjust this margin and manually push it in, pull it out, so it confines the edge of the prostate for planning purposes. But I always like to be with cryo just a little bit extra if you want to be past the edge of the prostate if you're treating. But we know that the peripheral zone is negative because it was sampled. We have our urethra, which is here, you can make out. There's part of the prostate urethra, that little white area right there. We can pull it in so we're only in that lobe of the prostate. And just for the sake of training today, you have an idea what everything looks like. In the upper right, you're looking sagittal, and the lower is the coronal. But we're going to pick our cryoablation protocol, cryo. It has some defaults. It says a 6 and 10 millimeter margins, but it's also going to identify the bladder, rectum, pubic bone, subvessel, urethra, and urinary sphincter. So now it automatically did that. That was in real time. Now I have a 3D model of the prostate. The thing that's good for when you're beginning is if you want to, you can see where the pubic bone is, and you see how the pubic bone may obstruct our view. On here, you can select if the pubic bone is a no-go, which means it won't plan where the needles go because the bone's in the way, but I prefer to look at it, and then we can come up with a treatment plan. Let's go back to our original window where our treatment plan was. It did make a 6 millimeter and 10 millimeter margin. For the sake of today's presentation, I'm going to delete the 10 and leave the 6 millimeter margin, which is here, which we can select and adjust just like I did before, just like you're doing segmentation. Drag, pull. The more you pull, it behaves just like the UroNav interface you're used to. I think because we know it's going to go 5 millimeters past the edge, I can put a probe here. I can pick the type of probe. We're going to use the ice pearls. Click add, and then I drag and drop. And you can see we can plan around the edge of the prostate, and we can optimize how we place this. Now I want you to see that there's gaps in the front of this probe, and we're working our way around, and it just helps you easily visualize what you want to cover. Notice how the margin you draw is completely arbitrary, but looking at where the lesions are, you see we have two areas here that are not kissing perfectly. Most likely we'll be able to observe them during the procedure. They should come together. And you can see here is where you should be worried. If you're planning and learning focal, you're like, oh, I think I should add another area to make sure I cover that that area that may be undertreated from what I'm looking at. And you could add another probe if you wanted, whoops, to cover that area. This is, I think, excessive. This is a 95% plan for the margin. You have 100% coverage of the ablation zone. You see it's completely tucked in there. Depending on the type of needle you use, you can pick. You don't like to use Galil? Fine. We don't use Galil. We'll switch from Galil to Endocare. 15 millimeters minimum spacing between the probes. We don't have to do pullback ablations on this one because the type of probes they have a V probe, which is long. They have a 4 centimeter. You see how big the ablation zone is? And I can pick the size of the ablation zone I want to use. So let's first of all find a location. I think this lower corner is a nice place to give us a good margin and work our way around. It's almost should remind you of the game in the 80s, the carnivals. We want to try to, it's a little low because we're going to miss that corner over there. And you can see what is treated, what is not, because you have it highlighted here. And see, I want to place one over another area. That doesn't make sense. So I'm working my way around the edge to make sure that we can cover the entire ablation zone. Now, as you look, we already covered the lesion 100%, but my ablation zone is only 91% covered. This is much more detail than people typically have for the procedure. We can close this and it'll save the orientation, so when I go back in the OR, I can replan, but I have at least an idea of how many probes I have to use, how long they have to be to optimize the treatment. This is another case of a patient that had 2 lesions that were sampled. Only one had cancer, which was in the anterior area. This was his confirmatory biopsy. He has been on active surveillance and decided now to have therapy for grade group 2 disease. You can see this is the outline. We're going to propagate this to all the other sequences. Again, you can see there's a co-registration issue. We can show the outline of the prostate boundary. There's a little extra right here we can go in and fix, but for the purposes of this talk right now, I'm just going to highlight going over this segmentation. I am going to create a new freehand ROI, but before we do that, again, since you guys are new to this, let's look at, well, what does a 1 centimeter margin look like? How far would that be? Would we want to freeze the bladder? I do not recommend freezing the bladder. Typically, we treat the prostate with a margin, and depending on what it is, we want to make sure it's safe. And just to give you an idea what 5 millimeters looks like, that's 5.8, 5, what 8 millimeters looks like. And as you get used to looking at that, it's 8.6. It gives you an idea how far to draw the ROI around the prostate. Typically with these small lesions, I will place my needles at about 5 millimeters away, and that'll give me an extra ablation zone of probably 9 millimeters, depending on the ice. But you have to be wary where the urethra is. So this case is a little trickier because the urethra is here in the midline, and we have the sphincter and the pubic bone. The angle of the lesion is directly anterior to the urethra. Typically what we do is we offset the stepper 15 degrees so we have a little bit more of a straight shot, and we'll raise the patient's hips up to see. So this is a reasonable ablation zone for something like this. We'll highlight around and notice I was a little close over here, but we have a normal BPH nodule. We have the peripheral zone here, and we want to make sure we have lethal ice to the area. If you're using cryoablation, you should understand how the technologies work, because if you place your needle on the edge here, you know it's going to traverse the area, because look at, I have the distance is approximately 2.4 centimeters, its longest dimension. Cryo needles are typically separated by 15 to 2 centimeters, 15 millimeters to 20 millimeters, and that's because the lethal ice between the 2 probes, each probe is considered that they can cause damage 1 centimeter away from the center of the needle. So let's create a good size ablation zone. And you can see clearly on the ADC map in the middle of the screen that there is no lesion coming and there's no enhancement. This is going to be a significant amount of over coverage for this patient. As we come down, notice that in the middle screen, the ADC and the enhancement's gone, but we're still drawing the lesion, okay? So we're just kind of guessing where it was before. On the top of the prostate, it's all fat. I'm not concerned about the nerves, but what I am concerned about is undertreating in the z-axis. So there's two below, that's 6 millimeters below. There's our small lesion. We're moving up, up, up. And look again, we draw a picture on top of that area of the area we'd like to treat. And you can see the bladder wall is there. We try not to treat into the bladder. The needles do not go into the bladder. But that's complete coverage above. And you want to look in the other, we're going to end the edit. I'm going to name this my ablation zone. And then we can propagate it across the other sequences to make sure it's covering any area. So it looks here posteriorly, there's some co-registration. So you see the lesion is and where it's off. I might put a little bit more posteriorly to make sure I have a healthy ablation zone. So I'm going to edit over here and bring it down a little bit more posterior. You can see it extend in the other picture, the other frame. So I think it's important to understand what we're doing. This one, I'm going to come a little bit more lateral here for visualization purposes because I'm looking at the DCE and there's where the lesion is, but it tracks a little bit more lateral than we expected. So I'm going to make sure that I include this in our treatment planning. With cryoablation, the needles do cover a significant amount of area very quickly, and this is a relatively small prostate. Now, on this sequence, I can put over here and show the prostate boundary. We don't know how, the co-registration seems pretty good. He didn't move that much during the study. You can see where the edge is. You see there's vessels tracking along the anterior portion of the prostate. That's not cancer. And then there's a lesion right here. I want to make sure that we have a good area, so I'm going to extend my ablation zone a little bit more lateral on that slice to make sure it's included. Even though I know that's a vessel, I just want all the enhancement to be gone, so when the radiologist reads the scan post-ablation, and notice that we kind of migrated across the middle a little bit. I'm going to correct for that now on that sequence to get the z-axis. So we have good coverage all the way up, and if you see there was a little tail over here on the left, I'm going to make sure that this area is ablated. So there's no chance that there's going to be cancer. And as you see me, I'm just pushing the ice all the way up here. Our total length of our ablation zone, you can see, is 2.7 centimeters in the z-axis. Width is 2.6 and height is 1.9. This is easily covered by at least 3 probes, and maybe 2 would be adequate, but I'll find out that tomorrow or when I'm in the OR doing the case. This is an example of a typical fusion screen and what data is available for your treatment. You have the upper left, which is your live fusion. Upper right is a review of the MRI and the target and the planned treatment with the ablation zone. The lower is a reformatted MRI, which is what's being used to generate this 3D model. And the lower right is a 3D representation of the treatment plan, as well as the grid if you're doing a transperineal approach and where you can place your needles. And the upper middle screen, you can see that the needle is going right through the target to be placed for visualization and treatment. This is an example of another case of using fusion. We've outlined in blue where we estimate the sphincter is on imaging. This black hypoechoic area is the ablation zone with the ice. Cryo is a modality that helps you understand where the energy is being placed. And you can see what you're treating. You can see the green was the target. The light blue down here is where the margin is. You have to make sure that you want to push ice even further than this still shot you want to be at least 5 millimeters past that edge to have a complete ablation zone. In the lower right, you can see we've outlined the urethral sphincter down the middle here, the sphincter as well in the blue, so you see a channel and where it is. This is off our screen. But up here you can see we've highlighted the urethra here in the middle of the upper right. This is an example of the advanced technology we have now to outline the entire pelvis, create a 3D model that you can use to plan for surgery or view cases for focal therapy. I think it's really helpful to learn the relationships where things are, albeit these models aren't perfectly accurate without you fine-tuning them. But however, it gives you a good understanding where disease is, and maybe it can help you in the future plan your treatments and even treatment decision-making for patients. I know that was a lot of information. I want to thank everyone for following through to the end of the lecture. If you have any comments or questions, please feel free to reach out to me via direct message on Twitter or X, and/or check out more videos on our YouTube channel. I really appreciate your time and your willingness to try to learn new things. Thank you again, and my name is Dr. Art Raston.